Hello, everyone, and welcome back to TIO 2022. This is the second session of day 2, Practical Pearls Toward a More Advanced CTO Program. Where are we in? Boy, is this going to be an exciting program. I'm Roxana Moran, coming to you live from New York. I'm delighted to be joined by this session by my dear friends, Dr. Ajay Kurtane from New York Presbyterian, Columbia University, Dr. Holger Thiel from Leipzig Heart Center in Germany, Dr. David Hildick-Smith from Brighton and Sussex University Hospitals in Brighton, UK, and so delighted to welcome Margaret McIntyre from New York Presbyterian, Columbia, not UK. It's wonderful to have you. During this session, we'll be discussing practical pearls toward a more advanced CTO program. I'd like to start first with opening a poll, the second poll of the day. Let's open this poll, please, everyone, over at in London. So in a patient with multi-vessel coronary disease that includes a CTO, I refer to surgery for CABG. I plan to test to detect ischemia/viability in the affected CTO area, or I consider treating the non-CTO vessels first and only consider the CTO treatment if complaints remain. Please vote. For our audience, submit your answer on the poll tab on the left side panel, as you can see it in front of you, and we'll come back to you and see your answers toward the end of the session. So let's start our first presentation where we're being joined by Dr. Ajay Kurtane in New York, who'll be presenting use of imaging and coronary physiology in the CTO space. Over to you, Ajay.
Well, thanks so much for that, Roxana. We want to keep it practical. So what I've tried to do in the next 8 minutes is to give some examples of the use of imaging and CTO physiology, at least in this space. I would be remiss if I did not thank Gary Mintz, Akiko Mihara, and Kadi Fall for slides, insights, really teaching me, because when I came to Columbia, I didn't use a lot of imaging, and now I'm over 90%. So this has really been a learning experience for me as time has gone on. I'll just start off with one slide on the data for IVUS-guided PCI in CTO lesions, long lesions. This is a pool level analysis, 4 trials showing reductions in adverse cardiovascular events, specifically stent thrombosis, TVR. This is the reason to use imaging. It's these complex cases, and we can really benefit our patients this way. We feel strongly that this is the way that these cases ought to be done. Now, in terms of how you do it, though, that's where the disconnect is. People understand the data, but can you actually do it? And so this is just a nice slide that Akiko has shown many times, where you look at how do you do it. You basically go to a reference segment that doesn't have a lot of plaque. You basically measure that segment, and typically you're not going to look at lumen sizing. You're going to look at the vessel sizing and then discount it a little bit. So if I measure 3.5, what I'll usually do is I'll use a 3.0 stent for that type of purpose. You then determine the length from an automated pullback, and basically that's how you optimize your stent results and get the lowest rates of restenosis for your patients. Now, one of the things that's important to remember in CTOs, though, is that because these vessels are underfilled, you may have different types of remodeling, negative remodeling distally. You can even have positive remodeling at areas of plaque. And what you don't want to do is size that big or undersized in some respects, because either of those things can cause a problem, either catastrophic like a perforation or potential restenosis. So remember that aspect of what you do. And it's also important to remember that as you do CTO PCI, the distal vessel can actually change in terms of size. And so this is just an example of it, where you see the distal vessel here in the LAD after the stent is placed, what it looks like first, and then what it looks like later. Typically, you're going to get enlargement of about 15 to 20%, but things that actually correlate with late enlargement are the LAD target, not a lot of calcium, and if the vessel is really, really small. So this is an important thing to remember when you size. There are definitely practices outside the US, like in the UK, for instance, where patients will come back for optimization of stents to make them larger as time goes on. This is just another example of the distal vessel, a case where you see stents are implanted, and this doesn't look like a great result, but by IVUS, it's not a ton of plaque there. And then in follow-up, this actually, there wasn't any plaque, it just got bigger over time. So this attribute of what to do with the distal segment is something that we may bring out in the cases that we talk about as the live cases are done, but you have to be judicious and not just stent all the way down and keep going with your stents as long as there's no hematoma. Now, other things that CTO or IVUS can do in CTO PCI is identification of a proximal cap. Here you see an occluded LAD, but you have a large branch of a ramus and a circumflex here. And if you use this eagle eye catheter, which basically has the transducer right where my pointer is, you can actually nicely appreciate where in the vessel the LAD comes off. So this is a pullback into the ramus. And in this segment right here, this is a characteristic appearance of the CTO lesion. This then is the circumflex. This is an open vessel. This is what a occluded vessel looks like. And by wiring, you can determine where your wire goes and actually confirm that you're in the LAD as you're crossing. And so as we go forward, this just has a build on the slide. Here's the wire, and now we see the wire is actually in that occluded LAD segment. So this is a pretty useful technique for larger proximal vessels where you can pass the IVUS catheter into an adjacent side branch. Other things that you can do more distally in CTOs are looking at distal wire position, for instance, with a retrograde. So in this case, this is the retrograde wire. It's subintimal all the way through, and now this is the true lumen. You know you're not in the right space. So if you're having difficulty during reverse cart and you're not sure where you are, you can use this technique to determine where you are. And over time, if you get into the true lumen, I'll just show you what this looks like. Here's just the example of the wire. Now this is actually in the luminal space, and therefore you feel comfortable that you've actually made the connection adequately in that sense. Other things that can be very useful with IVUS is determining if is it okay to stent or not. Because if you're distally not in the true lumen and you put a stent in, for instance, in this, if this was what your distal lumen looked like, you would basically be shutting down the whole vessel because the true lumen is here. There's a big hematoma here, but as you go more and more distal, you're now seeing a branch and you can put your stent in safely here. But if you stopped it in any of these other points, you might either shut the vessel down or never get back in because you're stenting with a big hematoma distal to where you are. So that's another utilization of it. In terms of whether the IVUS is useful at determining intraplaque versus subintimal tracking or extraplaque tracking, it can determine that, but it turns out that it really doesn't change what your outcome is. And this is data that we presented showing that once you adjust for the clinical characteristics of the patient, whether you were true lumen or intraplaque or subintimal or extraplaque didn't really matter in terms of the long-term outcomes. This has also been corroborated with an OCT-based study that showed that while you had more malapposition up front, the rate of uncovered struts didn't really matter whether you were subintimal or true lumen. So I think for the most part, it's not going to change whether you identify one versus the other, but if you're not connecting, it can be useful to put the IVUS catheter down. And by the way, you're doing that without injecting dye so that you're not going to make the lumen bigger. That's why I think this slide is important. It's very hard to identify a perforation on an IVUS image, but so often with CTO PCI, we don't give injections because we don't want to pressurize the lumen. And so in this particular case, what you see is disarticulation of the vessel, and this is what a perforation might look like. And you sometimes will have a sense of this with IVUS use before you inject dye, particularly for those contained perforations of the right coronary artery. So how do we summarize the use of IVUS? It can be very useful. Stent optimization is clear, but then additional things, ambiguous caps, connecting lumens, ensuring that their stent is going to be implanted in the right way, and then identification of complications are key ways that the IVUS can be useful in addition to optimization of stents. In the last couple of minutes left, I'll just talk briefly about physiology. We tend to not use physiology a ton for the actual CTO intervention itself, but it is interesting to note that this question of what happens with the donor vessel when you open the CTO has some data behind it now where it shows that the IFR in the donor doesn't change by a ton. It's 0.02 as a whole, maybe at late term follow-up, 0.04. FFR doesn't change by a whole lot either. So it's not one of those cases where, I mean, we've seen people say, well, the IFR is borderline in this lesion, so let me treat the CFO, then the CTO, then the IFR is going to normalize. It's probably going to only change by 0.02 as a whole. What's important, though, is the actual CTO you're treating itself also might not change a lot. In many cases, it increases. So 77% of the studies of patients in the study, it did increase, but we need to be really, really meticulous in optimizing our stents, because in this study, at 4 months, 40% of patients still had FFRs post-PCI less than 0.9. So if we're going to do these cases, which are at higher risk, higher rates of recurrent restenosis, we have to do a fantastic job of treating these patients. And that's the reason why we use imaging to optimize our stent results. The final thing I'll just show you really briefly is that there are other ways, non-wire-based technologies, to evaluate what you're doing in the cath lab. This was a case that Margaret and I did for the CTO meeting, CTO Plus meeting a month ago, where there was an LAD occlusion and a right coronary disease as well. We didn't do any wiring to assess the physiology. We did use something called angio-FFR, which is a cath-based technology. What we showed here is that the FFR of the LAD, which was occluded, was less than 0.5. But more importantly, there was disease in the right coronary as well, which was intermediate. And by using this angiographic-based technique, we were able to get a read that the physiology was okay. There was a lesion in the right, but the FFR by angio was 0.87. And what we ended up doing is successfully opening up the LAD CTO, and then we did a post FFR on that, demonstrating actually, incredibly enough, that there was normalization of the FFR post, which was 1. And we did not manipulate this or anything like that. So this was fortunate. I don't think this is a normal case that where you always see it normalized to that degree, but in this case, it was a good result after imaging guidance. So to conclude, in summary, how do we use imaging and physiology and CTO PCI? I think first, the use of intravascular imaging should be considered standard of care, all caps, for complex PCI, including CTO PCI. But you need to know how to do it in order to do it in these complex cases. So make sure that you're facile at that. IVUS has multiple roles, may vary by catheter type. Typically, the eagle eye is harder to cross, but it's the catheter that's most useful for guidance of cap penetration because of where the transducer is located. OCT has a role, but predominantly for post-stent optimization, because you don't want to pressurize the lumen. And then finally, physiologic assessment may have the role in the assessment of multivessel disease and dictating treatment strategies, but I would be cautious and beware of over-reliance upon this over anatomic disease burden. The future trial showed us this. If you have a lot of complex disease, that patient should be considered for surgical revascularization. And then if turned down, you can do PCI, but don't say, oh, well, that's borderline, so let's go do single vessel PCI in these patients. Post-PCI physiology might be an emerging target, especially in follow-up, but we need more data in that regard. Thanks so much, and happy to take questions.
Thank you, Ajay. What a wonderful, wonderful discussion on IVUS, and we have this great panel. So let me start with Margaret. You know, you're on the panel, so I'm going to use you up a little bit here. I mean, I know that you're a big proponent of the use of IVUS, but I also, you know, we saw these beautiful images that Ajay just showed us. And often what we're seeing is that most labs don't have a Kikos on their right side reading these and have a very difficult time in evaluating the proximal cap, understanding better what's going on in the distal vessel, and even sizing up. And I think what you did, Ajay, was great in kind of showing how to do it. What are you seeing? What do you think is the best way for a novice person who's just starting to do some CTOs and wants to use IVUS?
Thanks, Roxana. Great talk, Ajay. So I think that the key is getting access to knowledge in your environment. So if you're lucky enough to have someone else in your group who's experienced at imaging, then do cases with them and have them teach you and show you. And if you don't, then access education from outside, either by visiting other labs or have people come to the lab to teach you, or use industry. Industry will often provide great educational programs around the imaging space. And of course, in addition, there's now lots of great imaging courses to attend as part of bigger courses, but also that stand in isolation. And I think lastly, the most important thing is just use it. It's like everything else. The more you do it, the better at it you get, and the more confident you become at interpreting what you're seeing. So I think use imaging as much as you can and tap into any educational sources around about you that'll be helpful.
So Holger, what percentage of your cases are with IVUS guidance in CTO?
So yeah, difficult question because I do not have really data on this. So at least what I can tell you, so maybe I'm, because I'm an old guy, I'm an old interventional cardiologist, so I'm not using it so often, honestly. We use it in specific cases, but I do not use it in every case. So I would, if I should give an estimate, maybe 20, 30%.
But are you impressed with the data regarding IVUS guidance improving outcomes? And do you think that, is there a reason why you're not using it, or is it just that it's just more cumbersome?
Yeah, it's cumbersome, it takes time. There's also maybe a reimbursement issue in Germany. So this is also something which, like always, plays a role in the decision when to use it. So this is probably one of the key aspects why we are not using it in every patient.
You know, the revascularization guidelines for complex PCI did give IVUS guidance a 2A recommendation finally, and I think that's hopefully it could have an impact and hopefully change some of the reimbursement patterns. And I think it's the same in the European guidelines. David, what about you? Where do you see? What's your view on imaging? How often do you use it? Which imaging modality? And how often are you using physiology?
Yeah, so in CTO, we'll do plenty of IVUS. We obviously won't use much OCT. We'll use less FFR because it's less often relevant in that setting. But I mean, I'm interested in why it is that IVUS isn't taken up more in this space. Increasingly, there's evidence that suggests that if you use IVUS, you're going to get better outcomes. But I think what puts people off is the sense that they don't really know what they're looking at. And they don't really have the confidence that if they use the IVUS, they'll actually be able to influence the outcome of the procedure. So I think what Margaret says is right, that you have to get educated in how to use it so that you know that you actually make a difference by using it. Sometimes people use IVUS as a badge of honor. Oh, well, I used IVUS, so I did a good job, but that's no good if you didn't react to what you saw. And I think there's a lot of uncertainty about people being confident that they know what they're looking at and can respond accordingly.
Yeah, you know, it's really true, David, and I think that was sort of the reason for my first question, is that it really is difficult. I think those images are more difficult to interpret. Ajay, I know that you're a very big proponent of imaging. Would you say that even if you're uncomfortable, at the very least, to end a CTO procedure after all of that work, there should be an IVUS guidance for at least optimal stent deployment? What do you think about that, at least, at the very least?
No, I think so. And I think everybody sort of relaxes once you cross, but a lot more can happen after that point. And certainly for the patient, their long-term outcomes, that's important. Back to the training issue, though, really quickly, I also think a lot of it has to do with the actual images people are looking at. And the standard catheter that's used, the images, frankly, are very hard to interpret. And you're doing a manual pullback and it's jumping around and it doesn't cross half the time. And I think, honestly, that has held things back. And frankly, it's not just one company, because that same company has another catheter that actually works really well and is rotational and better imaging quality. And I think that is really important to address, because it's all good and fine for us to sit up here and say, image the CTO. But if the catheter doesn't cross, then throw it out the window. It's not going to be very useful.
Yeah, I mean, I think that was Holger's point. I have one last question before we go to Margaret. Holger, I'm going to come back to you. I mean, I'm fascinated by the distal vessel and how often I'm seeing stenting from stem to sternum, like literally complete vessel stenting. What are you doing exactly? And are you really convinced by the distal vessel, leaving the distal vessel, allowing the flow to actually help improve and increase the diameter? Holger.
Yeah, you are addressing a very important point. So often, at least this is my impression, if you're using intravascular imaging, this often also leads to more stents and longer stent lesions or longer stented areas. And so often probably, so in case we do not have a dissection and we have a nice apposition of the stents, often it is not required to use additional stenting, only based on IVUS. So in this case, I probably would more go for physiologic assessment if there's really, if there is ischemia, and would not rely too much on intravascular imaging. But this is more maybe a personal perspective.
No, absolutely. A really, really important point. Thank you so much, Ajay. That was a fantastic talk. We're going to see you in the lab. I'm going to say goodbye to you for now. I know you're going to your live case. Let's move on to our next presenter, Dr. Margaret McKendicott. So wonderful to have you here. And who will be on who will be speaking to us on novel CTO techniques. Over to you, Margaret.
Thanks, Roxana. So CTO PCI success rates have increased dramatically over the last 10 years. And I think this is largely due to the adoption of a systematic approach to how we plan these procedures. When you cross a CTO, you're either going to cross it by tracking intraplaque, either antegradally or retrogradely, or you're going to cross it by entering the extraplaque or subintimal space, tracking across the occlusion and then re-entering. And which technique you use is largely determined by the anatomical complexity of the occlusion that you're treating. Now, over those last 10 years, there have been multiple algorithms to guide an operator on how best to approach any particular CTO. And it's interesting, last year, we developed this consensus global algorithm as a kind of umbrella to guide the community both in the East and in the West. Now, interestingly, on reflecting on what are the novel techniques that are emerging, it's interesting to note that there appears to be a refocus back on the antegrader approach, and I'm going to focus on that for the rest of this talk. So if we start by looking at parallel wiring or IVUS guided wiring, rather than being a novel technique, parallel wiring is one of the oldest CTO PCI techniques. So in the original technique, what happened was when you tracked your first wire and it went subintimal, you left that wire in place as a marker of where not to go, also to occlude that space that you created. You took a second wire parallel to that and tried to cross again. The technique further evolved with the development of the single lumen microcatheters, which allowed better support and control of your wires and the ability to reshape the wire tip for better steerability in the direction in which you wanted to travel. The technique further evolved with the availability of dual lumen microcatheters. So if the first wire went extra plaque, you could track the dual lumen on that wire. That wire then stabilized the dual lumen microcatheter, again giving you even better support and control of your second wire to try and cross the occlusion. And then more recently, the technique has become even more sophisticated with the availability of the dual lumen triple exit port microcatheter or the recross catheter. So with this device, what you can do is if your first wire ends up extra plaque, you can take the device in, you then have a second exit port 8 millimeters back from the tip, you can try that. And if that's unsuccessful, you can then bring back your first wire and access a second port on the opposite side of the microcatheter, 12 millimeters from the tip, giving you another option for wiring. You can also, if your second wire is no good, you can actually trap the microcatheter out and then re-deliver it on the second wire. And then that gives you another two options from the two side ports again. A further development of parallel wiring is using IVUS. So what you do is if your first wire goes into the subintimal space, you track the IVUS on the first wire, you then come parallel with a microcatheter and a second wire, and you use the IVUS to let you see where you are with your second wire. So can I have the next slide, please? So you use the IVUS on the first wire to allow you to see your second wire in the microcatheter to determine whether your course is tracking intraplaque or whether, again, you're entering the subintimal space. So an additional use of IVUS, in addition to all the other uses that Ajay's already discussed. So what about the antegrade dissection and re-entry techniques? So up until recently, the only device available for controlled antegrade re-entry was the Stingray device. And what is now referred to as the classical ADR technique involved you entering the subintimal space with a knuckle wire, tracking the knuckle wire partly across the occlusion, then taking in the cross-boss catheter, finishing your track in a controlled manner with the cross-boss catheter, using a support wire like a Miracle 12, delivering your Stingray balloon, and then using the Stingray wire to re-enter the lumen. You then had to, because of the barb on the tip of the Stingray wire, you then had to do what was called a stick and swap, where you removed the Stingray wire and then swapped, for instance, for a Pilot 200 wire to then rewire the vessel again. Now, over the 10 or 12 years since ADR has been available as a technique, this technique has dramatically evolved. So these days, what we do is we use a guide extension to control the subintimal space. The biggest failure mode of ADR is hematoma in the subintimal space that compresses your target. So now we use a guide extension to try and prevent hematoma accumulation. What you're going to do is you're going to get into the subintimal space, track a dedicated knuckle wire, such as a Gladius MG, which is designed to specifically form a smaller knuckle. And then it means you don't need to use a cross-boss device to finish off your subintimal track. And then after you've tracked your knuckle wire beyond the occlusion, you can often actually go straight to the Stingray balloon without having to use a support wire, unless you're dealing with a calcified tortuous segment. And then again, instead of re-entering with the Stingray wire, most operators now will re-enter with a Confianza Pro 12 or Hornet 14, some kind of high penetration force CTO wire, which you can then stick through and drive into the distal vessel rather than performing a stick and swap. So this has made the procedure much more efficient and improved success rates. So coming back to the recross catheter, this is given as a second option for device-based re-entry. So what you can do here is, because the recross has these two exit ports on either side of the microcatheter, if you end up subintimal, you can track that after your first wire, and then you can explore both ports and see if you can re-enter the lumen beyond the occlusion. Now, the downside of the recross in comparison to the Stingray is, because it doesn't have a balloon or two balloons, you can't inflate the balloon and anchor the device, which is thought to control the position of the device and allow you a more controlled and more powerful puncture through into the lumen. But on the upside, because it comes with a stellate in the second lumen, it's more deliverable than the Stingray device. So if you're dealing with calcium or tortuosity and you can't get the Stingray device down, this is a good alternative option. In addition to that, one other nice advantage of this device is it has two hubs at the back. And what that allows you to do is you can connect a syringe up to one of the hubs, and you can do negative aspiration on that hub to decompress the hematoma in the subintimal space while you're simultaneously sticking into the lumen. This in itself can actually stabilize the catheter in the subintimal space by decompressing the subintimal space and expanding the target that you're aiming for. So the last thing I want to mention is antegrade fenestration re-entry. So antegrade fenestration re-entry is a technique when your first wire enters the subintimal space. You then come parallel with a second microcatheter and wire. You put a balloon in the first wire, and you inflate that balloon, and as it's deflating, you're going to try and wire into the true lumen. And you can do this with a lower intermediate polymer jacketed wire, such as a Cyan Black or maybe a Gladius. This technique is quite simple to perform, but I'd say it's much less predictable than the other re-entry techniques. And at the moment, the consensus opinion is that we should only adopt this technique if we've exhausted all our other options and we've decided that we're happy to perform a modification procedure and come back and complete a completion procedure in 2 or 3 months' time. So in conclusion, I think the novel techniques and developments in CTO PCI have really been more of a refinement and fine-tuning of the established techniques that we've had. And this has been supported and facilitated by a further iteration and a further stepwise development in the wire and microcatheter technologies that we have available. Thank you.
Thank you, Margaret. That was fantastic. I learned so much. I think I need to take a masterclass with you. But before we begin the discussion, I'd like to welcome back Nicholas Van Meegen on the panel for the remainder of the session. Since Ajay left us. Hi, Nicholas. It's wonderful to have you. So let's begin the discussion. I'll come back to you first, Margaret. You just showed us these wonderful, it seems like we're going back to the antegrade instead of kind of having those crazy retrograde approaches that we all learned for years and years. And I love seeing all these new techniques that you just showed us. But all of this, what do you think in terms of training and our trainees? Does this mean like you got to take a year and come to your lab and learn from you, then work with you before you start doing the antegrade fenestrated penetration? I mean, it just seemed to me like difficult one to do, that last one.
Yeah. So, great comment, Roxana. So a couple of things. So one, I think the move back to antegrade has been driven by a few things. I think one, as we've got more successful at CTO PCI, we're now really focused on that 20%, 10 or 20% of cases that we can't complete. And more importantly, that complication rate. So to make CTO PCI really accepted and mainstream, we need to deal with both of these issues. And I think that looking at the data, some of the complications are concentrated around the cases where we're forced to go retrograde because of the complexity of the anatomy. So I think this kind of refocus on antegrade to try and come up with new ways to deal with these vessels and avoiding high-risk retrogrades like the epicardials is important. Following on to the training question, I think you're entirely right. I think now CTO PCI is at a stage where people really need to do dedicated training. Ideally, if you can manage in fellowship, but even as an attending, so I, through my 10 years of practice now, have spent a lot of time, training some of the other attendings round about me. So I think much like structural, it's something that if you can get it on fellowship and get a dedicated period of time where you get high volume exposure, that's ideal. But if not, and I think if you're lucky enough to have someone else in your center who's fully trained in all the techniques, and I think buddying up with them and accumulating exposure to these more complex cases is the way to do it.
No, thank you. So David, coming to you now about antegrade versus retrograde. I mean, it seemed like to me that we were so focused on the retrograde approach and not really giving the antegrade. Where is the field going on CTO?
Yeah, I think I'm really pleased generally that antegrade is coming back, and I'm especially pleased to see that the parallel wire technique is making a resurgence. A few years ago, I was at a conference, and there was anyone using the parallel wire technique, and I kind of stuck my hand up, and there was hardly anybody, and it really went out of favor for ages. But actually, it's a really good technique, and Margaret described it beautifully. Great slides, really simplifying how it should be done. So. And I agree. Obviously, there was a while where people were doing epicardial to show that they could. And you see, oh my God, look, the SU03 will go around that epicardial. Isn't that absolutely incredible? But yes, but that doesn't mean that you should do the case like that. And so I think having done that and had some complications, obviously known about with particularly friable epicardials, you can get into terrible trouble with that. So if there's a way of safely completing the case antegrade, again, Margaret expressed it really well, that will allow more acceptability of CTO into the mainstream, because there's still this concept that the CTO operators are a tiny bit crazy. So to bring it all back into the main fold would be really good, because actually when you learn how to do CTO, you get so many tips and tricks for your ordinary PCI that you sort of feel almost everybody should have exposure to this to get better at ordinary PCI.
So coming to you, Holger, I mean, what's your approach? Do you plan the case both ways? I mean, it seems to me like you look at a CTO and you say, I'm going to go antegrade, but when do you decide to then go retrograde? And then can you just give me some ideas of how you choose your wires? Because I think that's also a very, very sort of tricky part as well. And maybe Margaret could then pitch in.
Yeah, I think this is important that first of all, you always have to have a strategy on the way you want to really reopen the CTOs, and you should have it in advance. And at least what we do, we usually, like probably many people, that we start usually antegradely, and in case it does not work, we have the option for sure to go retrogradely, and you always have to assess if there are enough collaterals or septal collaterals where you can get through. And this is probably very important. But I will cover this in my talk, and we can maybe discuss this later on for how long you should try to do it antegradely, when you should consider to do it retrogradely. I brought a case, and maybe this will be helpful also for further discussion on this.
Yeah, no, I'm looking forward to that. Nicholas, I remember years ago, probably before you were born, that we were watching cases from Erasmus at Rotterdam, the CTO cases. And a few years back, I saw a lot of co-registration with CTA that was being done right in your laboratory with live cases. How often do you think that's needed just to know what the course of that vessel is and guide you for CTO? How often are you doing that? And then my second question to you as the director of the lab is, do you have a dedicated person and a dedicated day for CTOs in your lab? Do you think that's the most optimum and the most efficient way to proceed?
Yeah, these are excellent comments. First of all, the co-registration, unfortunately, we're not doing that at the moment. So there has been quite an extensive research line in the past using co-registration. I think it can be still valuable for complex CTO procedures, especially if you are unaware of the length of the lesion and the kind of occlusion that you're facing. What is your target? What is the amount of calcium? So I think it still makes sense to do pre-procedural planning using CT, but it is being underused. In terms of focus of a CTO program, yes, we do have 2 dedicated CTO operators. Our case volume is around 200 CTO cases per year. And we try to pool those cases on a Monday where the 2 CTO operators are around. So I personally still do CTO procedures, but I also have to be honest. These more refined techniques are first being taught and being learned by our CTO experts, and then they're diffused to the other operators in a more gradual fashion. But I think this is clear. Practice makes perfect, and if you only do these techniques once every 3 months, you'll never become a good operator.
It sounds like with all the nods that everyone is agreeing. Any comments from the panelists? Extra comments?
No, I agree with Nicholas.
Well,
I think
so
it's important.
Yeah.
So I have a question then for Margaret. Margaret, how do you deal with a general interventionalist who keeps on trying with the CTOs, but shouldn't be trying?
This is a great question, because the thing with CTO PCI that's a bit different from structural. So I've been doing both in the last couple of years. And the lack of segregation between CTO and non-CTO PCI is quite interesting when you see how segregated structural is out from CTO PCI. So I think there is this kind of gray area of where it becomes CTO and not. So what I've tried to do with the younger operators in the group in Glasgow was that I encouraged them to take on the easier cases. So the GCTO 01s.
I want to do the poll first.
I would talk to them about, encourage them to maybe use the Xion, maybe an XTA, and maybe a Scion Black. And then if at that point they were stuck, they should stop and then refer the case on to me and discuss it. But the other thing I've also taught them, which Holger's going to talk on, is I've taught them how to do investment. Because if they're doing a case that they don't think is so difficult and the wire gets subintimal, instead of that being a negative thing, teaching them that if they balloon it, it's going to help me the next time the patient comes back. And that also encourages relationships between the non-CTO and the CTO guys. And there isn't this barrier of So I think it's okay to encourage people to use some of the safer wires. And as David said earlier on, it improves their skills in the non-CTO cases as well. So that's usually what my approach to it is.
That's great. Well, Margaret, before we let you go, I wanted to share the poll results with everybody. So let's put those up. So
Yeah, I agree.
it seems like most of the people are looking to detect ischemia and viability in the affected CTO area. I think that's a pretty good idea. What do you all think?
Yeah. Yeah.
Yeah, makes total sense.
Good. Well, this is great. Thank you, Margaret. We're gonna let you go, and we're gonna let you go. We're gonna see you in the lab. I know you're joining Ajay for a great CTO case. We can't wait to get to you. But I'd like to introduce our final presentation now by Holger Thiel, who joins us live from Leipzig. Holger will be presenting on goal-oriented mindset in CTO procedures, when to persist, when to invest. Over to you, Holger.
Yeah. All right. Thank you very much, Roxana, for the nice introduction. I will give it a goal-oriented mindset in CTO procedures. And the question is when to persist and when to invest. And as already mentioned, I brought a case where we really tried 3 times to open it, and we can discuss this later on. So I have no conflicts of interest regarding this specific talk. So hopefully it advances. Yes, all right. So this is the case. So this is a patient who was referred to us because he was complaining of angina. And as you can see here, there's a chronic total occlusion of the RCA, and there's also chronic total occlusion of the left circumflex. And probably the RCA is relatively small when you look for this. And the LAD was, maybe there's a plaque in the mid-LAD, but there was no significant stenosis in the LAD. So we have a 2-vessel disease in this patient, and with a CTO of the RCA and a CTO of the left circumflex. And when we are looking for the location of CTOs, you can see it's the majority of the CTOs is in the RCA, 16% in the left circumflex, like also in our patient, and 20% in the LAD. And in 17% of the cases, more than one CTO vessel is present, like in our patient, which I brought to you. The treatment reality in CTO is that roughly in current practice, based on, based on what we see from registries, that only 10 to 15% of the patient really, a PCI of the CTO is offered. So the question is now, when to open it, for which reason, for which indication. So in this case, for sure, we should consider it because of symptoms. And this patient had typical angina with a CCS class of 2 to 3. Regarding prognosis, this is, as you all know, the randomized trials did not convincingly show that there is a prognostic improvement if we are opening CTOs. And there are many rational and dilemmas of CTO PCI. We believe that there's a reduction in ischemic burden. This has been shown. We also consider that the completeness of revascularization is beneficial. Improvement of symptoms has been shown in randomized trials. Improvement in LV function has also been shown in many registries. And we believe that there's a reduced predisposition to arrhythmic events and ischemic events. We also aim at the avoidance of procedures and reduced medication. Survival benefit currently has not been shown. And then what we have just learned also from Margaret McAntegard is that we have technical and procedural challenges, misperceptions regarding viability and collateral flow, and also uncertainty regarding which patients may really have a benefit, and also complications play a role. When we look for the guidelines, at least the European guidelines, for our patients, there's a clear indication with the 2AB recommendation because of angina. And in case there's a documented ischemia in the territory of the occluded vessel. And this is also the reason why we performed a cardiac MRI in our patient. As you can see it here, stress perfusion, there's clear ischemia with more than 7 or 8 segments in the left circumflex territory, not in the RCA territory. And as you can see it here, there's also enough viability for our patient. And that's the reason why we decided to go for CTO recanalization in this specific patient. So this is the first attempt based on all what we see. So this is according to the JCTO score sheet. This is a, this is 3, as you can see it here. So there's a blunt stump. There's also some bending. The lesion length was more than 2 centimeters, summing up overall to 3 points in the JCTO score. There's always some delay when I try to advance the slides, sorry. So what we also have to consider, this is also regarding what kind of wire we are selecting, that we always have to look for the proximal fibrous cap, if there are microchannels, if there are calcified areas. This is what we have to keep in mind when we are also making our selection of the appropriate CTO wires. So this is what we did. So the first attempt was a right radial access, 6 French. We used fine cross microcatheter. We tried to do an antegrade recanalization. We first used the Fielder XT, then we had used the Progress 80, and then we went as a third option for a Gaia second. But we stopped because we were not successful in this case. After 1 hour, 25 minutes procedure time, radiation was relatively high, contrast dye 350 cc at an estimated GFR of 85 milliliters per minute. So stopping rules, well accepted stopping rules, first of all, for sure, are complications, a low likelihood of success with further maneuvers. And you all know the different complications. This is a nice overview just published in JACC Intervention. And then there are also procedural metrics, like procedure time more than 3 hours, contrast volume more than 3 times the estimated GFR, what we had in our patient at the first trial, air karma of more than 5 gray, patient fatigue, and maybe also operator fatigue, which may also be present in some circumstances. So there may be exceptions if there's significant progress made and the completion of the procedure is foreseen with minimal further effort. So we decided 4 weeks later or 5 weeks later altogether to do a second attempt. This time we have chosen the femoral access 7 French, extra backup 4.0, antegrade. We used the fine cross microcatheter, Fielder XT, and then we went for Gaia second, and we also tried to approach it retrogradely using septal surfing with a Xeon Blue. But we were, as you can see it here, 2 wires, and we were very close, but in the end we were really not able to do it. And we stopped after a procedure time of 2 hours and 10 minutes. Radiation once again relatively high, and this time contrast dye was a little bit less. We had a small perforation at the left circumflex retrogradely, no pericardial effusion, but the patient also had some fatigue, and that's the reason why we decided to stop once again. And we talked to the patient and said, okay, we will be able to do it, but we need another try. And this is what we did. Another 8 weeks later, we did it, and this time the LCX was retrogradely recanalized with a reverse card, and the obtuse marginal, we did a controlled puncture through the implanted stent in the left circumflex, and this is the final result, as you can see it here. It's a huge vessel, and the good news also is that this patient had no symptoms anymore at follow-up. So this was successful, but as you can see, we needed 3 approaches to reopen this chronic total occlusion. Maybe for the discussion, also for you, Roxana, for the panel, the question is, do we need more RCTs focusing on CTO? What are the challenges of the previous and also the future CTO trials? Are there maybe too many different phenotypes, and maybe also the heterogeneity of the operators may play a role? And then we also have selection bias, because everybody wants to open a CTO, and maybe we have a selection bias also in the previous randomized trials that the high-risk patients were not included into these trials. And with this, I would like to thank you, and I'm looking forward to the discussion.
Thank you, Holger. What a great talk you just gave us on some of the practical issues that we all face. When do we stop? When do we? How many times do you bring back an unsuccessful CTO? When do you refer to a more expert operator? These are all really, really important. And then lastly, how do we do clinical trials in CTOs with all of this heterogeneity and difficulties? So why don't I start with you, David? Which part of this calculus do you want to take apart? How often? How many times do you try a difficult CTO?
So I think I read a great talk. I loved it. I want to borrow some of what Margaret said, actually, because I think that this division into CTO and non-CTO operators has been a little bit unhelpful. And it is important to enfranchise people who want to do CTO procedures to be able to start and progress. So I really liked what she said about having a relatively simple toolkit, try and make some progress. If you don't make some progress, recognize your own limitations and say, okay, now I refer to the regional expert in CTO and let them have a go. So I think in general, 1 attempt per operator is sensible. Beyond that, okay, there's always an apex of a pyramid where somebody is the regional expert, and so they might have 2 goes. I must say, I'm not sure I would have a 3rd go, unless I thought there was a special reason to do so, but that was a great case, and it really helped illustrate your talk. But it is the kind of procedure where you do sometimes make sufficient progress that it is very tempting then say, I'm sure if we come back in 2 or 3 months, we'll be able to complete this. And often you can.
Yeah, I mean, I think, it's a difficult one. And I like the idea of giving people a little bit of a chance. But I think it's those expert operators where, you just know you're going to get it, but you've already gone 300 cc's of dye. It's been 2.5 hours.
Yeah.
And I think that was a really nice example of showing that it's better to, give the patient a rest. What do you think, Nicholas? Are you in line with that?
Yes, I totally agree. I think this was a very elegant presentation of realistic perseverance. I think it's okay to persevere and aim for success, but sometimes you need to invest, and this concept of investment is quite important in contemporary CTO practice. Rest assured that also the super experts sometimes need a second chance, because sometimes you arrive at a crossroads during a procedure and you decide to go left, and afterwards you realize, should have gone right. Basically, Holger, when they did their second attempt, they realized we came so close, but we need to back off, because they arrived at a crossroad and they realized at the end, we should have gone right, but if we go right, we'll nail it. And I think that makes total sense. I think the caveat there is if you keep on persevering in that same procedure, and then it becomes like a marathon. The operator gets tired, the patient really is in pain, is in agony. that you should avoid that. And this is an exercise in discipline that we also discuss on a regular basis in my practice.
No, really fantastic, and I think that these are difficult choices of what to do. Now, let's turn the attention to the last slide of Holger, and I think that's a really important one. I'm a clinical trialist, and I don't want to say, I can never say that we could just stop doing trials because it's just too difficult to do this in CTOs. So I have a solution, but I'd like to hear what the rest of you think. So why don't we start back with you, Holger? What do you think should be done? No trials, just use anecdotes, or do the trials like you've done with all the most difficult patients? On CTOs.
Oops.
Oh, okay.
I think we
we'll
lost
get Holger back in a second. Yeah, we'll get him back. What do you think, David?
Yeah, so I think it's a really difficult field. I mean, because as with many technologies, once the technology is available, it's really hard to randomize patients to not receive it. As we've seen in PFO studies, CTO studies, the Euro CTO trial, it was really hard to recruit, and some of the highest risk patients didn't go in. Some of the simple cases didn't go in. A lot of the operators who were referred cases from far away, those cases wouldn't go in. So it was an unrepresentative sample in the end that actually got into the study. And with CTO, you can show, I think fairly straightforwardly, that you get an improvement in symptoms, and the Euro CTO trial did that. For showing hard endpoints in terms of reduction in episodes of myocardial infarction, death, stroke, etc., it's really pretty hard. And I must say, I'm looking forward to hearing what your solution is, because I'm not sure that I see an easy solution for doing a CTO study successfully to demonstrate what we all hope is true, that is, there is some real benefit other than purely symptomatology in doing these CTO procedures.
Well, here's what I think. I think that we've had a lot of arenas where we've known it's very difficult to do these clinical trials, especially in strategy trials. And in my mind, one of the most successful groups are the Cardiothoracic Surgical Network, where they choose the surgeons who are on there. Everyone agrees to a certain set of rules and a certain set of definitions, and they basically answer questions that are important to their community for their work. And actually, a lot of it becomes very, very much pertinent and very, very much relatable to our practice. So we've seen, mitral repair during CABG, yes or no. These kinds of questions that have nothing to do with a certain company promoting a certain thing. These are really important. So my proposal is to have a CTO trials network with the kinds of operators that have expertise. So we take that out of the equation with the definitions that everyone agrees to, that the kinds of CTOs that they would be evaluating that everyone agrees to, and the strategy and the techniques that everyone then agrees to. And then you answer questions, retrograde or antegrade, retrograde first or antegrade second, or vice versa. And I think everyone could answer really, really important questions. Right now, we're left with a lot of unanswered questions in this field. And as you saw in the revascularization guidelines, they got a 2B for CTO. And I'm not so sure that that's right. I'm not so sure that's right. It should be better, but I'm not so sure we got it right. What do you all think? Nicholas?
So I think, sorry.
Go ahead,
David,
Nicholas,
go ahead,
first, and then we'll come back to you, David.
Okay, so I think that there is an intrinsic limitation to randomized controlled trials, right? Because they only relate to the study population, to the selected study population, and I think that is key. I think we need to be better in defining the phenotype of the CTO patient that we're investigating, and I think it's a mistake to pretend that all CTOs are equal. So that would be my solution. I think first make a very good definition of the CTO phenotype that you want to study, and then it may not become so difficult to, even in terms of clinical outcome, demonstrate benefit, and also introduce a screening committee. In the structural heart space, we nowadays have these screening committees that will decide which patient would be eligible based on the inclusion-exclusion criteria, but also on the phenotype that you're studying. I agree you will have then a selected patient population, but at least it becomes a pure study. And you can then make inferences from that study. But this is how I think you will get a high-quality CTO randomized controlled trial.
Well, this has been a fantastic session. What a wonderful set of talks. We began with Ajay Kirtane, who really discussed the use of imaging with CTO, and then Margaret showed us some of these fantastic techniques with the antegrade technique, as well as a great discussion and a lecture by Holger Thiel regarding what to do and how to persist and how to give up and how to evaluate and use some of our clinical judgments when we're treating CTOs. The discussions have been great, but now it's time for some live cases. So let's go live to New York, to Columbia University, New York Presbyterian.